attending today. It looks like we've got a really great turnout, and I can hear there's still a lot of people downstairs, so please don't be disturbed by people pouring in as we go through the session today. I'm Rob Knott. I work for Lewisham and Greenwich. I'm here today to help Joint Health run this special event. Just by way of background, how this came about, I'd been attending numerous conferences over the last 5 years and was conscious that we had some super events, often very functionally led, focusing on IT and finance and digital and innovation and so on and so on. And I always kept posing that same old question, which is, so where's the magic wand? How do all these amazing interventions miraculously turn into contracts with relationships with suppliers, and how do we cover the subject of procurement? In fact, why don't we think about integrating that into an event about innovation and digital and so on, so that not only do we encourage more buyers and professionals from procurement to these events, but also give the opportunity for people selling into the NHS to meet those individuals, and also try and break down some of those barriers that we often find when particularly innovations in the digital health space start to be want to be adopted and diffused across the NHS. So we thought we'd put a little bit of different shape to it, and I hope this will become a common theme for Joint Health in the years to come. So I won't go into a massive sales pitch for Joint. I think you all know what a great organisation is. I've got a statistic here. That represents a community of 345,000 innovators, companies, individuals, all keen to connect and share their insights, but also to make a massive difference in the NHS with their particular technologies or inventions or innovations. But today we've got a really excellent differentiating agenda. We've got developments from the Department of Health, which David Lawson will touch on in the next few minutes when I allow him to do so. And we've got Ed James, who again is a senior procurement leader in the NHS, to share many of his insights. We've also got some really hot topics around the digital procurement approach to ambient scribing, AI. One of the really big hot topics at the moment is the strategic procurement of medicines. If Donald Trump can stop, I'm not supposed to touch on politics, sorry, for a moment, if you can stop messing with that global market. And at the end of the day, we've got two great sessions running off with a big session on clinical procurement. We've got two very senior clinical leaders who work in procurement organisations, which is something of a rarity. And we've got an incredibly exclusive discussion between Jin Mackey and Roy Lilly. But look, I'll canter through to the part of the agenda which is to do with procurement. Just throwing some statistics out there. It is apparently we spend somewhere between 54 and 62 billion a year across the entire NHS. That's top to bottom with suppliers across about 110,000 suppliers. That represents a significant life sciences industry. Not surprisingly, at the top of the house, the Department of Health is bringing together life sciences and commercial procurement underneath a single national leader for the first time in NHS history. This means that the 10-year plan has got a completely different level of focus. We're talking about things like data, AI, genomics, wearables, robotics, alongside the three shifts. But we can't deliver against these new strategic problems with the same solutions. We've got with the same a consistent or persistent focus on price. So one of the things that has come out, and I'm going to give you a couple of quotations here, there have been calls for procurement to move on from being compliance-driven and transactional to becoming entrepreneurial problem solvers, and for their function to act as a strategic policy lever to securing economic growth. So that agenda is shifting much more away from price towards value. So that brings me to the first of our keynote presenters. As I say, you can see the way it's been structured this morning. Each of the keynote presenters will come up. Then we're going to have a panel session with me, Ed and David, and that's when we'll be taking Q&A from the audience as well. So now I'll hand over to David Lawson.
Thank you. Thanks, Rob. Can you hear me? Yeah. For the Q&A, Rob has already prepared 7 pages of questions for me and Ed. If you haven't got any questions, so my plea for today is to please put your hand up for Q&A. Otherwise, we'll have to revert to Rob's very tricky questions. I think the ones I saw. So let me just introduce myself. So I'm David Lawson. I'm the essentially the med tech policy lead in the Department of Health and Social Care. Been in the post about 3 years. Before then, I was procurement lead at Guy's and Tommy's for about 21 years. So I've come from a kind of NHS kind of procurement background into what I describe sometimes as big school, into a policy role. And essentially, my role is around supporting adoption. So we're very good in the NHS at innovation. Lots of fantastic innovations right across the NHS, but the ability to uptake the most effective innovations effectively across the health system is often seen as a challenge. So a lot of my team's work is around how do we get better and how do we come as a health system more effective at the adoption of the most effective technology across the NHS. So sometimes I describe myself as a plumber. It's very much about trying to improve the kind of pipe work in terms of how innovation is adopted. I do normally break the clickers. It looks like I may have broken this one. There we go. So if you're selling into the NHS, this is often what you see. It's very much, the NHS is very much like a series of doors, often padlocked, and the majority of med tech is bought at a local level. So if you're trying to sell into the NHS, you have to kind of go through multiple kind of separate hospitals, each with their own kind of processes and approaches. And it can be very challenging because of that kind of fragmented approach. And what we hear from startups and even established companies is the same kind of message in terms of this kind of high friction environment where it's difficult for to kind of sell into the NHS, and this can slow the adoption of the most effective innovation. I was at last week we had a kind of away day in the team, and we had some startups. We had Nick, Rebecca, Ash, and Ben, and these are people from the Clinical Entrepreneurs Program. So they've got clinical background. Each of them have worked in the NHS for a number of years. Each of them have developed in their own area kind of fantastic innovations. And what they talk about is this high friction environment where it's very challenging for them, particularly as startups, to be able to get access into the NHS. And so, some of the kind of comments that they gave the team last week was just the kind of difficulty where different hospitals are operating in different processes. Sometimes it's one person in an ICB or a trust that is holding up the ability for that organisation to adopt. But he also talked about the importance of the kind of champions. And Nick, for example, on the left, he said that for his technology, it's used by, I think, about 250,000 patients have kind of had benefit from his technology. But that's on the basis of only 5 clinicians across the NHS who've taken the initiative and given their technology a chance. So, but what they're calling for is is really for the NHS to be a better customer, and to be more consistent, so that they know what they need to aim for, so they can operate in a way to kind of promote their technology. So in terms of what we're trying to do, in July you had the 10-year health plan published, and in the same month you also had the life science sector plan, which very much is a follow-through from the 10-year health plan in terms of recognizing the importance of life sciences, both to achieve the kind of transformation of the health systems. The 10-year health plan talks about the kind of 3 big shifts, and life sciences is seen as a key enabler, but also recognizing in the 10-year health plan that this issue of adoption is a challenge, and therefore we need to kind of put forward some practical improvements to improve adoption. So the life science sector plan is very much the kind of to-do list of kind of key actions across the innovation pathway, from improving and speeding up clinical trials to improving regulation right through in terms of procurement. But also the life science sector plan recognises the role of life sciences in terms of growth as well. And sometimes ministers talk about the Department of Health not just being about healthcare and the health of the nation, but also being about economic growth, and the department being a department for economic growth. So there's a recognition of the importance of life sciences and in particular medical technology, not just from the ability to transform health outcomes, but also in terms of its role for growth. So in terms of specifically around procurement, there's 3 kind of key initiatives that we've been working on. One is called Rules-Based Pathway, which is essentially providing a clear national adoption route for the most effective technology, where through that route funding will be provided and implementation will happen. And then the following 2 around value-based procurement and looking at product comparison and passporting. This is about trying to enable local decision makers to make more informed decisions more quickly, and also to improve the consistency of those decisions. So I'll just kind of walk through these very quickly. What the rules-based pathway is essentially trying to do is replicate the existing adoption pathway that you already see for branded medicines. So if the adoption pathway for branded medicines, the way it works is that NICE are asked to do what's called a TA assessment, a technology assessment. And if that technology assessment is positive, then there's a statutory obligation for that medicine to be adopted throughout the NHS. So simply what the rules-based pathway is doing is replicating the same process for medical technology, where going forward, the Secretary of State will commission NICE to assess specific technology topics, and if the assessment is positive, then it will be adopted throughout the NHS. And what this is intended to do is, as well as trying to address this issue about funding, it's also about ensuring total adoption, so you don't have this kind of postcode lottery situation. And there's examples in the past where the NHS has had national funding allocated to technologies, but they haven't been adopted throughout the NHS. There's been resistance to that adoption. So the TA process is partly about providing that clear national pathway, but also about ensuring total adoption in terms of that technology right across the NHS. In terms of where we are with this process, over the summer, NHS England led a kind of prioritisation exercise where they identified a long list of technologies. A lot of that was driven by the national clinical directors, ensuring that the technologies that were identified were the ones that the system wanted to have, so there was a pull factor, because there's no point in the centre identifying technologies in isolation of the health system if the health system on the ground don't actually want those technologies. So they got to a list of 13 technologies, 13 categories. They were then sent to NICE, and they have a process called their NICE Prioritisation Board. And from that list of 13, they got to a short list of 4 technologies that were most suitable and ready in terms of data to be referred for a technology assessment. They're now with ministers to make a decision. We're hopeful that after Christmas, the next step will be that NICE will take forward those, will be asked to take forward those TA assessments. So we're quite we're quite far ahead in terms of where we are in the process. And that the intention then from next year is that this process becomes a kind of ongoing dynamic process. So as technologies with high impact, where there's a pull factor from the system, are identified, then there'll be a question about whether they can be referred via Secretary of State to NICE to do an assessment. So the aim is that over time this becomes the routine adoption pathway in the same way that is already in place for medicines. We then have value-based procurement. So in many ways, this is designed to do two things at the same time. So one thing is around recognizing the importance of outcomes and impacts of technology and ensuring those kind of qualitative factors are assessed. But also at the same time, it's simply about consistency of process. So at the moment, there is no single methodology about how to assess medical technology. There's no single standard about what the score system should be. And this is why you see lots of variation, both at a local level between trusts and even within procurement teams within a trust, but also at a national level between national category teams, because there's no kind of single standard. So the aim of the value-based procurement methodology is, yes, it's about recognizing value as opposed to just lowest cost, but it's also simply about trying to introduce a level of consistency, so that from a supplier perspective, you know what you need to aim for, you know the type of questions that you're likely to be asked, and therefore you can develop the evidence base to ask them in a more routine way. So the way the methodology works is relatively simple. Sometimes I describe it as the Ladybird Guide to Procurement, but essentially you have a maximum weighting for cost at 40%. You have the 10% weighting for social value, and then the remaining 50% is based on these kind of qualitative domains. And it's up to each buyer when they're going to have to do a procurement exercise to select the domains that are most relevant to them and most relevant to what they're trying to buy. And behind each domain, there's 5 or 6 kind of standard questions that then can be selected based on relevance. So it doesn't take away local flexibility, but at the same time, it's trying to introduce a level of consistency in process. So in terms of where this is as an initiative, we've spent the last year and a half working with both industry through trade associations and also kind of procurement teams to kind of develop the methodology. We did some shadow testing with trusts in the spring, just to kind of get a sense, could this work in practice? And at the moment, since last month, we've got 13 hospitals across the country applying the methodology into live tender exercises, and then NHS Supply Chain and the London Procurement Partnership applying it into 4 live tenders for national framework agreements. So the aim is to take the learnings from those pilots and then early next year do any final kind of iteration and then to launch it by kind of spring, so late March into April, to apply this as the kind of standard methodology. So again, in many ways it's trying to fill a kind of gap where at the moment there isn't that standard guidance, and you see this kind of large variation in process. And then to kind of help that methodology, we're also developing a kind of digital tool to very much to provide greater visibility of options available for medtech and where the evidence is. So one of the challenges for medical technology is sometimes there's so much choice, and therefore from a buying perspective, how do you make an informed choice? How do you trust what a supplier is saying about their technology? How do you know whether to believe them? And if you haven't got that, then what can happen is it kind of delays a decision. It takes longer for a decision to be made, or sometimes the wrong decision is made because a hospital wasn't aware that actually there was a more effective technology, just weren't aware of it. And if you're an SME, which doesn't have the same resources and kind of brand awareness of some of the larger companies, it's hard for your technology to be on the radar of those decision makers at a local level. So the MedTech Compass digital system is very much about just trying to raise awareness of what options are available And then against each of those options, where are there kind of validated existing information and evidence that can be presented in one place? For digital technology, a key pain point is around DTAC standards, for example. There's a national standard for DTAC, which is around kind of information governance, data security, etc. But it's administered at a local level. So one part of the thinking of this new system is to, with the help of NHS England, is to have a national registry for DTAC and present that information in one place through a Compass tool. And similarly, with NICE, you have early value assessments of kind of emerging AI technology, for example. But it's hard to navigate to find that guidance if you go to the NICE website. So the aim of this tool is if you look at the category where NICE have done an early value assessment, you'll see that information in one place alongside information on, say, DTAC compliance. And if there's other kind of trusted evidence, again, it's presented in one place. So this is about trying to speed up local decision making and but equally making sure that decision making is as informed as possible. So where we are with this process, we did what's called a discovery phase in the spring, just to kind of validate that this kind of made sense as a digital tool to develop. We passed that discovery phase. Since September, we've been in what's called an alpha phase, where we're kind of testing different design concepts to understand, as a system, what would make this system useful for people to actually use on a day-to-day basis. And then from there, the aim is to then go into beta phase next year to kind of develop it further. To make this system work, we're also in parallel building a national PIM, a product information management system, which will be a single repository for all medical devices with their UDIs, their unique device identifiers, and that's working very closely with MHRA to also support their post-market surveillance work. That baseline of an accurate PIM means that a system like this can then be kept up to date on an ongoing basis. One of the challenges with these type of tools is how do you keep it up to date? So again, we're kind of making progress in terms of developing both guidance around value-based procurement, but also kind of digital systems to kind of systemize and make decision-making at a local level, hopefully more consistent and quicker as well. So why is this important in terms of growth? Well, at the beginning, I talked about the recognition of, in terms of the 10-year health plan, the life science sector plan, around the importance of medtech, both for kind of improving health outcomes, but also in terms of economic growth. So an example here is Convatec, where a couple of months ago they announced £500 million investment in a new R&D facility in Manchester. So if the NHS can be a better customer, if it can provide smoother adoption pathways into the NHS, if it can be more consistent about how it buys, then it provides a positive signal for industry to invest in the NHS into the UK in terms of basing their R&D facilities and other support facilities into the UK. If we're a difficult customer, that doesn't attract the investment. People will invest in other countries. People will leave the UK. Another example, I guess, in terms of SME. So the majority of medtech as an ecosystem in the UK is SME based. So here's an example of Pennine Healthcare, who manufacture devices in Derby. They're working very closely with the prison service. They're providing job opportunities for ex-offenders to work in their factory and to reduce the risk of reoffending. If you are a prisoner on release, if you don't have a job to go to, you have a 1 in 2 chance of reoffending. Whereas if you find employment, that goes down to 1 in 5. And it costs the economy about 17 to 18 billion a year in terms of reoffending. So SMEs in particular have a great role within their kind of local communities in terms of wider impact. And so if the NHS is a good customer, we can support and sustain companies like Pennine, who are doing great work from a social value perspective as well. If you look at the UK as a whole, the other aspect of medical technology is that it employs people right across the country. So from Inverness manufacturing diabetes test strips to kind of syringes manufactured on the south coast, it employs more people than pharmaceuticals. So there's sometimes a bit of a competition within life sciences between the importance of pharma and med tech, and pharma is kind of dominated by these big global multinationals, whereas the profile of medical technology is these kind of smaller companies based right around the country. And medtech employs more people than pharma. So this is why doing things around improving procurement process in the NHS is important for growth as well as kind of improving health outcomes. So I'll stop there, and I think I'm handing over to Ed. Yeah.